Welcome to The Deliberate Way, the podcast that explores the deliberate way that innovators approach their craft. For those who don't know Dr. Bellorin, Omar is the director of GI Metabolic, Bariatric, and Robotic Surgery at Holy Name Medical Center in the great state of New Jersey here. And amongst the many accolades and accreditations, maybe one of the most notable about Omar is that he's completed more than 1,200 robotic surgeries, many in bariatric, over the years he's worked in this space. And, aside from being a gifted surgeon who's helped countless patients, he's also one of the leading minds around this notion of healthy and sustainable weight loss. Because, losing the weight is only part of the issue, but keeping it off, that's the big problem that everybody struggles with. So it's great to talk about this. And I'm going to jump right in, Omar, because over the past few weeks since New Year's has passed, I noticed seeing that Forbes as this survey that they put out, and they claimed that 2 of the 5 leading New Year's resolutions were, of course, losing weight and improving fitness. And they're always, right on the top of the list. So as an expert in this space, I have to ask you, why is weight loss always at the top of people's personal goals? Why is it always there again and again and again? What do you think?
Well, first off, thanks for the candid introduction. Listen, weight loss, it's always at the top of our daily, problems, so to speak. If you think about it, obesity or being overweight, it's a pandemic, and the United States is not far from that. Statistically, we are 40% overweight or BMI over 30, which is considered obesity type 1. And if you count out of every 10 people, that means that 4 or 5 of them are going to be either overweight or obese. So it has different implications. So it's in the top of the mind of people every year.
I got to ask you, you were not born in the United States. And is this every bit of an issue in other countries? I know it's a naive question, but when you think about it from also from a clinical standpoint, like viscerally, I feel like, yeah, there's overweight people all over the place. But is America is that like our chief export is overweight people, or is it sort of a pandemic in that it's in every country right now and just as big of an issue?
Yeah, no, this is according to CDC and also the World Health Organization. You can see that Canada is also a big problem, and also Asia. Okay, it's mostly North Asia. You see also South America. It's a big problem. Obesity from all the way from Mexico, all the way down to Brazil, Paraguay, Chile, Argentina. It's both. It's genetic predisposition, but also it is environmental. But I have to say that the top 3 countries, according to the World Health Organization, is United States, Canada, and Australia. Well,
mm-hmm. So we're in good company. It's I want to just kind of wind back for a moment. I mentioned that you came from another country, from Venezuela. Take me back for a moment about how do you get involved in bariatric surgery? Coming from Venezuela specifically, I know as a young kid you wanted to be a surgeon, and it kind of turned you on to it. But bariatric's a really specialized area in my mind, and also the idea of weight loss. What turned you on to that? Why bariatric? Why weight loss?
Yeah, so I think once you become a surgeon, as physician, first off, you really have that commitment of helping people and trying to make lives different. I think bariatric surgery, what fascinates about this is that you can really make a dent in patients' lifestyle and life changes. You really are part of their transformation process. Mm-hmm. You can actually see how these patients, you kind of unleash the person that's been inside. Somebody who has been having obesity issues for the longest. You can see, stories like, doctor, I don't have any more diabetes. Now I ran my first, half marathon, my first marathon. It's rewarding. The other thing is that you have it's like a long-standing commitment with the patient and you. So it's not just the surgery; it's just you keep following up these patients, regularly, inclusive once a year, so you cannot see their modifications. And I think that is what grasps the best out of bariatric surgery is the capabilities to witness that.
Mm-hmm. Well, let me. I'm going to be a little provocative for a moment. There are people, not myself included, but I'll voice those people that believe bariatric surgery, it's just a shortcut for people who are, to put it bluntly, who are lazy. They don't want to do the hard work of diet and exercise. That takes time. That takes habit change. What do you say when people, make that allegation? What's your reaction to that?
So bariatric surgery is not a shortcut, and non any of the obesity related measurements for weight loss, so to speak. The way I see it is that you can see this as a pyramid. Okay, everything that you do is a tool for weight loss. Of course, you have the diet and exercise program, which is the base. And then on top of that, you can add, the medications, the endoscopy procedures, and of course, the surgery. You can tell that the surgery is a little bit more of an aggressive, but it's the only proven method for long-term weight loss. But if you think about it, it's out of every people in America who's eligible for bariatric surgery, only 1 or 2% goes for bariatric surgery.
And let me interrupt you for a second. When you say about eligible, who would be eligible? Like what does that mean exactly?
Correct. So, in order to standardize what is best for who, we have a measure which is called the BMI, or the body mass index, which is a relationship between the weight in kilograms and the relationship divided by the square of your height in meters, and that gives you a number. And normal is 20, roughly 20 to 25. But if you're 25 to 30, that's overweight. And over 30 is considered obesity. And then you have obesity type 1, type 2, type 3, depending on how much you have. But if you have BMI of 40 or more, then it's considered morbid obesity. So to be eligible for surgery, you have to have comorbidities, obesity-related comorbidity, which is hypertension, diabetes, or sleep apnea, which is the most three commons, and a BMI of 35 or 40, in between 35 or 40, let's say. And if you're 40 or more, whether you have it or not, you're eligible for surgery. So those are the two kind of elements, and this is NIH criteria, and they developed this in 1992, and it's been since 1992 the same premise. Although we're evolving into having people from, obesity type 1, 30 to 35, who have, severe comorbidities to start getting the surgery. Because if you think about it, somebody whose BMI is 32, but very difficult manage diabetes, then you don't have to wait for this patient to become more obese in order for them to be eligible for surgery. So nowadays we are, the society is pushing more for this type of patients who are not, obese enough, so to speak, to go into surgery.
Let me just ask you, putting it into context, how many people fit that criteria of over 30 BMI or even that morbidly obese? Like, are we talking about like a couple million people? Like, how
Well,
big
yeah,
is
this
it?
is CDC, and this is 2021. It's 40% of Americans.
40%.
40% of
40%
Americans
are over 30 BMI, or
30
40%
BMI,
are more?
correct. 30
Yeah.
BMI, considered obese.
Wow.
And then if you see, there is also uh, differentiation. If you see non-Hispanic blacks, it's 49%.
Wow.
That's almost 50%. If you get Hispanics, and this is America and CDC, right? So 44.8%, and non-Hispanic whites is 42%. So it's, if you go into different categories or ethnic groups, then you can see more of a difference.
Yeah. Let me pivot for a moment because I'm going to ask you more about bariatric in a moment. But, when I think about, putting on, the news, like the past like few weeks or so, I've been very kind of sensitized that every time I put on kind of like network TV, not that anybody watches that anymore, but, if you did, I feel like every other commercial is for Ozempic. And I never even heard really of what Ozempic was. And I work and do a lot of work in the life sciences pharmaceutical space. I didn't know much about it. And then I dug in a little deeper. I found there's over 270 million views of the hashtag for Ozempic. It's pervasive, like every commercial, every day. It's like become almost like a part of like the media landscape right now. And if I feel like it was a sudden onset, I know it wasn't that sudden. Um, is this a golden age of weight loss medicines? Like, is this like the start of something? Will we see many more Ozempics out there? And why does it feel like all of a sudden, like it just came onto the horizon out of nowhere? So that's multiple questions, but you attack it the way you want to. Like, what do you think about the rise of Ozempic?
Yeah, so specifically with Ozempic, and it's very interesting that you know it's not the first drug that has been developed for obesity or weight loss. Think about it, specifically with Ozempic is one of the so-called GLP-1s or glucagon
Hmm.
peptide like one agonist. This is an hormone that's being produced in our gut. And the first, you know, research about this was when patients after bariatric surgery, we saw these type of hormones very, very elevated.
Hmm.
And this is a gut hormone that is being produced at the end of our, so to speak, our small bowel, goes all the way to it's called the ileum, and it gets stimulated by food. So if you create any sort of bariatric surgery that goes and diverts the food quickly to that area, then you're going to have a raise in GLP-1, the
Hmm.
actual hormone. And the GLP-1 does a lot of stuff in the human, in the metabolic aspect of it. Okay, first one is, it goes to your brain and starts uh, uh, modifies the satiety, right? You get more satiety, early satiety, less hungry. Also in the liver, the heart it seems to be a protective for cardiovascular risk.
Hmm.
Also, the GLP-1 stimulates insulin production. Okay, so it was very at the beginning, and Ozempic is FDA approved for diabetes.
Hmm.
It can be off-label use for obesity at higher dose,
And
and that's why
it wasn't approved for weight loss originally,
no Ozempic
even
in
though that's the whole,
2017, correct.
yeah,
And then the same company developed uh, Wegovy.
Wegovy.
Wegovy is the newly one. It's the FDA approved it in 2022. And it's this GLP ones, and you also have Saxenda, Manjaro, okay, uh, different companies with the same principles. A GLP-1 agonist, different names. They're delivered by injections, and lately these ones are once a week.
Hmm.
It also caused some delay in the gastric emptying, and this is kind of the Achilles tendon of this, because some patients have, chronic nausea, feeling dizzy, fatigue, and it's all related to the slow emptiness of the stomach. These are the things about Ozempic. Um, I don't know if that answers some of the questions.
Well, I guess, like maybe more to the point is like, so there's been an explosion of different products, but all of a sudden it seems that there's been like a marketing blitz of late. Was it just the time because of the approvals of these products, or do you see anything else? Maybe it's also New Year's and people are more susceptible to it. Do you see kind of any of these patterns in your practice of
Definitely.
a lot more inquiries and more people asking for it, looking for it, even people who are maybe borderline, not overweight, but are more for vanity purposes? What do you
Yeah,
see?
so let's put it this clear. These are uh, approved for weight loss if you have a 27 BMI. Now we talk about BMI. So
Hmm.
this is what medication for weight loss approved. or should be indicated. 27 of BMI, so you're overweight, but you have any sort of comorbidity, hypertension, diabetes, high cholesterol, etc., sleep apnea. Or if you have 30 of BMI or more, with depending on whether you have comorbidities or not. So you see that indication is a little bit more flexible than surgery. Um, I think the boom is because, if you think about the first ones are phentermine, Topamax, the Xenical, the Kisimia. So Xenical, I would say, is just one thing, but the phentermine, topiramate, Kisimia, Belvic, etc., they all were like brain. They will kind of go into your hunger nuclear in your brain, basically decrease your appetite or make you less hungry, etc. They'll have a lot of side effects. Okay, side effects. Hypertension, patients with insomnia, with anxiety, panic attacks, etc. And it's very difficult for the patients to continue with that medication. So it's usually 3 to 6 months, and you see how they do. But when the GLP-1 came, they really worked. The longest studies are for 5 years, 68 months. Okay, usually with Ozempic and Wegovy, and you see how there is a substantial reduction of weight loss. And let me put this in perspective. In order for you to know how effective a drug or anything else, you kind of need to know how much of the weight loss or percentage of weight loss this thing is gonna achieve in around a year or so of follow-up. So if you take bariatric surgery, that is 30 to almost 40% of your total weight that you're gonna lose on average over the course of a year. And, somebody with 300 pounds, that's close to 90 to 100 pounds. When you go to medications, non-Ozempic related, right? This was classically 5 to 10%. Now, if you go to Ozempic, Saxenda, Wegovy, all of these GLP-1s, they're 30% of that people are going to reach at least 15 to 20% of weight loss.
So does that mean that potentially that this will be an alternative for bariatric surgery?
Yeah, it's definitely an alternative. I don't think it will. We definitely, as bariatric surgeons, we're seeing less people coming in for bariatrics. But historically, it has happened in the past. If you think about, we can talk about the gastric balloons, right? Gastric balloons were also FDA approved in 2015, and 3 balloons came out to the market. Everybody was getting the balloons. Nobody was going for bariatric surgery. The caveat is that FDA only approved those for 6 months. You have to remove the balloons, and then when you get the balloons out, the patient regained the weight.
Right.
It's a circle, and also the balloons were very expensive, not covered by insurance. You also have the endoscopic procedures, endoscopic gastroplasty, which is similar to the sleeve gastrectomy. Also out of pocket, is not covered, not the best results. So, you see that also now with the Ozempic, Wegovy, and all that.
I want to come back to something you mentioned about the older medicines. So I recall back in the late 90s, early 2000s, you mentioned the drug Xenical, which was a product made by the Swiss manufacturer Roche, who I actually worked for a period of time. And I remember, the kind of the scuttlebutt, the news on the street was this product was going to be a revolution. It had a massive financial forecast. They expected for, droves of people, and it didn't work as well as they had hoped it would. And one of the reasons that was pointed to is almost more of a punchline for a lot of like late night, stand-up comedians and, for kind of just, side jokes and the early memes out there, was that when somebody used a product that they would experience oily discharge or oily stool, which, there were stories of people, getting off their office chairs or out of their cars, and they had a very unpleasant experience. They'd soiled themselves. And But this side effect wasn't seen in the clinical trials. And when I asked one researcher, well, what happened? Why is it that in the real world we're seeing all of these side effects, but in the trial you didn't? And he said there was a very simple reason. When we did the studies, people were eating very clean, very restrictive diets, exercising, but in the real world, people were going to Burger King and McDonald's. They weren't exercising, they weren't eating clean. And so that kind of brings me to this thought about this next wave of products. What's done in the clinic doesn't always perfectly imitate what happens in the real world. Are there causes of concern or any canaries in the coal mine from your standpoint when you think about the next leading products out there in the weight loss space?
Definitely, Dan, because it's exactly what you're saying. We need longer follow-up studies, right? With Senecal was exactly what you said. The Senecal was just a malabsorption of fat. It will not absorb fat, but nobody told the people that they need to eat less fat, because the more fat that you eat, then the more fat is going to go through the GI, and you're going to have, continence and, large amount of greasy, bowel movements and everything that comes with it, right? The same is with phentermine and all those, right? So we, when they came out, it was great, and still some people use phentermine for weight loss, and it works for some people. And I think this is what's going to happen to the new GLP-1s. I think the gastroparesis is a big one. We don't know how long this, if it's reversible, if it's something that is just as you use the medication. Certainly, some people have been dropping Ozempic and Wegovy and all this because of that. Imagine you having a lot of acid reflux and feeling full and nauseated all the time, fatigue, vomiting, etc. Depends on how you tolerate this. I will think that there's going to be more research, and also the population is going to start to kind of get to realization, and also the prescription of the prescribers as well, because the FDA reported in October 23 that is a back order for Ozempic and Wegovy.
Really?
If you think about Ozempic, and Mounjaro, those are the ones that are approved for diabetes. So there are diabetic people that are waiting for those medications to be back in the shelves, right? But because there's not enough, there's this balance in offer and demand because of the reason we have been describing, then these people are getting affected by that.
So is this kind of there was I guess a bit of a dynamic, going back again to the 1990s when Viagra was first launched. It was approved for erectile dysfunction, but it became in some cases like a party drug for some people. And I know people weren't necessarily writing prescriptions for that, but nevertheless, things get used off label or for alternative purposes. Is there the risk, or is it out there that you'll have Hollywood actors and actresses to maintain their kind of fit appearance, who have to sometimes go up in weight, go down in weight? Is it something that people, do you expect, would use for other reasons, vanity or otherwise?
So definitely, social media and also the Hollywood celebrities, they are the ones who have been, and this is just me witnessing it, how the hype about these drugs started, because you can tell that they were freely speaking about it, and social media before and after and all that. It's interesting that you never know exactly what are the reality behind these things, right? Because like I'm telling you, 30% of people who do 20% of weight loss is not that much either. Right? So you can see these dramatic changes, and it's not what everybody's going to experience. It's important to send that message out. Everybody reacts differently, and statistically it's 30%. So it's like 1 in 3 people who's going to have at least 20%, which is not superior, but it's more than 5 to 10%. Majority of people, it's going to do 5 to 10% of weight loss. Like if you're 200 pounds, you're only going to lose 10 to 20 pounds.
So to play the contrarian for a moment, though, if you're somebody who is, overweight, let's not even say morbidly obese, you're overweight, you're probably feeling a high degree of urgency of, to lose weight. So you're probably willing to roll the dice. Do you see the motivation is there, and it's hard to probably to combat that, and maybe it's a good thing overall. I don't know your thoughts about even people have marginal gains. That's better to have those marginal gains because there are the other secondary effects of being overweight: depression, loneliness, isolation. There's other physical comorbidities that go along with it. So even a small gain might that be kind of the juice might be worth the squeeze, so to speak.
100%. I think as long as the patient, understand that any of these things are not going to work by themselves. This has to be, like I said, the pyramid. Diet, exercise, and lifestyle modification is kind of the big base of or the foundation of all of this. Unfortunately, and this is already studied in these papers, that once you stop the medication, there's a chance that you're going to regain the weight. The same happened with the balloons, and no more. It can happen, but it happens less with bariatric surgery. So everything has risks, right? But I think, like you said, everything has a gain as long as the patient embarks into a very solid plan. Not just like something I'm just gonna start doing and see what happens.
Well, I'm glad you say that, because I'm gonna gather you talk to hundreds of patients, post-surgery, pre-surgery, who are going to be facing a new reality, and they've likely gone or will go from being clinically obese to having a more normal body weight, and it's a pretty big transformation. What are 2 to 3 deliberate practices that you recommend or encourage your patients to follow to prevent relapse and return back to their former weight? What would you, and I know there's the off the shelf things you hear every time you'll see on USA Today or People magazine, but as a real insider who sees and talks to a lot of people, what are some of the habit changing practices that you would recommend for them to do?
Yeah, so again, I always, and this is what I tell my patients, anything we do, it has to be with a solid base. And I think the base of this pyramid of, healthy diet, for example, you have to try to limit your calorie intake. Okay, so it's the FDA recommends 2,000 calories a day. And basically, it's not that difficult. You have to cut the carbs, right? And the big carbs are the pasta, the bread, the rice, and the potatoes. Basically, you cut those guys half, or try not to, or at least one meal, or not all 3 meals. Then you're doing it. The other thing that I recommend is the lifestyle modification. Again, the FDA approves at least 150 minutes of exercise a week, which is 30 minutes roughly every day. And, combining some muscle strengthening exercises, because if you increase your muscle mass, you're also going to decrease the chances of glucose intolerance, etc. And then number 3 is the follow-up. Okay, whoever you decide to start this with, you try to follow up, try to get, check-ins. You can do it with your physician, you can do it at your gym, you can do it at your own house, but kind of circle back to see what are the gains, the goals, and what the expectations are.
I have to ask you one follow-up about these more deliberate practices. These all sound reasonable and sound and very familiar. Habits are hard to build, and they're even harder to change. I'm sure you must come across people like they have their morning coffee with a ton of creamer, or even just the other day I shared an article just about how it's still conventional wisdom for a lot of people. You should drink a tall glass of orange juice, which most Most docs are saying, nope, that's not a good idea. That's like eating 4 pieces of fruit and really loading up on sugar, which is not great for your body. How do you get people who have been so entrenched in their habits to be willing to, and to even try to shift those habits? Because even though they've gone through, the surgery, they still have to contend with the everyday. Like when you open the refrigerator or you're working from home, that's the hardest part. Like, how do you guide them on that?
Yeah, that's exactly how, understanding that the patients are not alone, right? So if you're going through a process of either medication or any surgical weight loss, there should be a team behind this. It's usually, um, it's very difficult to change drastically any of these things. So you have to usually work with a nutritionist and
Mm-hmm.
also be the committed person and also have a support system. I think the support system is a big one. You see patients that come to my office and they tell me, doctor, I'm the only one who's trying to do this in my house. I'm trying to eat less, and then I sit, and then the table is full with all these things that I cannot eat. So of course, next time just bring your parents, bring everybody here, and I'm gonna talk to everybody. So that is, and to the point that I have been operating on entire families, and
Wow.
this is
Entire
very
families.
entire families. This is very positive for me. It's a positive reinforcement. It's
Wow.
great. It's gratifying that I have operated the mom, the dad, the daughter, and the son, and everybody changes their way of living and practicing the daily lives, and that is the key. That is the key because everything else is a tool, but if it doesn't
Mm-hmm.
change from within, it won't change.
I love that input, that advice, and I think that really goes that level deeper that people need, which is habit change takes time, and it does require commitment, and it may even be adjusting your environment around you. If everybody is eating an enormous meal every day, and they're eating unhealthy things and ordering fast food, it's so easy to relapse. So can you change your environment? Can you get your support system to help guide you? I love that as a practice. Easier said than done, but maybe that's the next one that we do, which is about how do you really create a support system that's supportive.
Right.
Um, Omar, I've got one more thing for us to do.
Yeah.
And this is an opportunity to test your knowledge with a game that I like to call myth or reality. So here's how it's going to work. I'm going to have you as my contestant, and the game is weight loss, myth or reality. So you're an expert, should be easy. But what I'm going to do is present you a statement, and then I'm going to ask you to tell me if you think it's a myth or reality. I don't have the answer, but I'm going to press you a little bit to see what it is, whether it is truly a myth or you think it's a reality. So you ready to play along?
Let's do it.
All right. So our first myth or reality question. Body mass index, or BMI, is the best measure for determining if a person is overweight or obese. Myth or reality?
That is reality.
It is.
Because that
No.
is what you know the FDA, the World Health Organization, all the determining factors to classify whether somebody has overweight, obesity, or not is the BMI.
Is it, and I'll ask one quick follow up. Are there other surrogate measures, things that maybe aren't so obvious that could be as good, if not better, of a predictor from your experience?
Yes, I mean um, the glucose. Okay, the early fasting glucose, for example,
Mm-hmm.
the tolerance curve tolerance of glucose or glucose after 2 hours. The girth measurement. Okay, um, the weight by itself. Um, those are kind of the cholesterol levels, your hemoglobin A1C. In order to have you an idea how is your metabolic situation.
Mm-hmm.
But I think the one that is really easy that you can check on your own and titrate at least, once a month or once a week is the BMI, your weight.
BMI. All right. You heard it here. It's a reality. All right, next one. Obesity has more to do with your genetics than it does with your personal health choices. Myth or reality?
So if you put it this way, it's a myth because they're not mutually exclusive items.
Tell me more.
So there's a component of genetics, right? Definitely, it's there. You can see family of obese patients and a family that patients that are non-obese. So that kind of can run in their family. The other thing is the environmental, your personal health choices. You can decide not to use that route. I have patients that come, doctor, I do not eat, anything more than, no, I restrict my carbs. I do not do any more snacking. I use only protein and I still can lose weight. So you can understand, and you ask a little bit in the family history, that is a genetic component. And the other one is the one that's snacking all the time and that family does that. I would say that it's both. Both are determinants of how your weight is going to be throughout your life. There's one that you can modify for sure, and that doesn't mean that you won't respond well to these measurements that we're talking about.
Well, I wonder, Omar, if people who are more inclined, let's say, to seek out fast food or fattier foods, that they have a genetic predisposition for, and it's not a conscious choice. You could say you could consciously reject it, but subconsciously, or it's in their genes that they crave it. Whereas there are other people, they could give or take, take it or leave it. I don't need to have it, so they don't crave it at all. And others, it's almost existential. It's part of who they are.
Yeah, it's part of, how your insulin metabolism is, your glucose metabolism, how your centers, like you're saying, the satiety centers and the hunger centers, those are where the cravings are formed, etc. Those are things that are within you. Difficult to curb sometimes, but,
I'm going to throw out a new myth or reality for you. Ready?
Yeah.
All right. Obesity is about willpower, not biology. Kind of plays off our last one. Your thoughts? Is that a myth or a reality?
I would say it's a myth because it's a combination of both.
Yeah. Talk a little bit more about that.
You have to have, biology again. It's how your body reacts to different, scenarios. For example, you and I, we can get a sugar monitor device, and we are fasting, the both of us. And you and I, we're gonna take the same amount of sugar, let's say a brownie, right? You'll see you're gonna react different than I react. And everybody's individual. So there is some sort of biology there. That means that your cells are, your glucose, you probably have more muscle mass than I have, and your glucose is gonna go into your muscle mass immediately. Whereas me, I don't have much, and it's just gonna linger a little bit more time, and that means that it's going to go into lipogenesis and get it into into fat forming cells. So that's sort of the biology behind the genetic biology component. And of course, willpower, it's exactly what you're saying. I cannot get that brownie, so the brownie's there. But for example, you're a fit guy, Dan. You're not gonna get the brownie. Oh, the brownie, boom, the brownie. You know what I mean? Like, is that also right? The willpower is like, no, we're not going to provoke ourselves because we are in this mindset now. And it eventually becomes a habit. To your point.
Yeah, that's really interesting. And there's something you brought up. I'll just ask you maybe just to speak for a moment about this. The quantified self. I recall that you actually ran an experiment on yourself, so you don't just talk about it, but you actually do it. of measuring your blood glucose. And I mistaken that you were tracking your blood glucose and seeing how it varied over the course of a day, a week. So you could make better choices for yourself. But tell me a little bit more about that and kind of what prompted you to do that.
That part I'm telling you about research and diet and dietitians and nutritionists. That is the part that is just so individual. This is the glucose, the continuous glucose monitor, CGM, and there are many brands, and they're very approachable and really not that expensive to get. So what this is going to do is basically see how you react to certain carbohydrates. For example, I cannot eat white rice. If I eat white rice, I spike really, really, high in
white rice. It seems so benign.
Interesting, right? White rice.
Did you know that
then
before?
I go brown rice, and it's different.
Did you know that before, or you this was a complete revelation from
revelation? Because what they say, they say, oh, try not to eat rice. But for example, I eat potatoes. I don't have the same spike as if I eat white rice, right? Or pasta, for example, right? So there are different food choices, so to speak, that you can try as individual. And I think, holding that CGM, you don't have to have it all the time. You can make an investment for like a couple of weeks or whatever, and just test what are the, grapes, for example. I can eat grapes, but orange juice is horrible. And it's how the nutritionists say, oh, you have to avoid this. They gave you a list, and then if you want to do a diet, you're like, okay, so now I cannot eat anything. But using this, you cannot tailor.
I'm down to grass, buckwheat, and goat cheese, and that's it.
Correct. Which then we can start talking about the diets, right? All this Atkins, paleo, it's exactly that.
Well, you raise a couple of good things. I've got a few more myth realities for you. Something my mom swears by even today, and I can't get her to reconsider it. Eating breakfast is necessary to lose weight. You got to eat a good breakfast, Omar. Is that a myth or reality?
I will say reality.
Really? Oh, my mom was right then.
So, and I think I'm going to put in this perspective. You want to load your carbs early. You want to eat as much as you want in terms of that, because you are less sensitive. You're more sensitive to your insulin in the morning. Anyone. And, to your point is, if you now, let's say you don't eat breakfast and you pile everything to eat very late, right? Some people eat at, I have friends who eat at 8, 9, 10 p.m. That is the worst time that you can eat. Because, again, your insulin, you're more resistant to insulin at night because you have the other hormones, the cortisol, the adrenaline. They are all starting to spike at night. And those are the ones who are going to keep your glucose out. Remember, the more your glucose is out, it's not being utilized, the more the glucose is going to go into form fat.
Now, I got to ask you then, intermittent fasting. You don't eat late at night, but you don't eat early in the morning either.
Correct.
Is that violating that myth or that reality that is?
So what I would say that because breakfast, doesn't have to be in the morning, really. Breakfast is when you break fast. So, right? So that is
a very good point.
Correct.
I associate breakfast in the morning,
correct,
and not breaking a fast.
You can break fast at 11 a.m. and that's your breakfast. But you're doing intermittent fasting, and that's the other great, concept is we haven't, intermittent fasting, not that we just discovered it. If you think about it, go all the way back when we were hunter-gatherers, right? We did not have a breakfast, lunch, and dinner, right? So we ate what we killed, we ate what we got, right? So it's going back to that period of time where you are able to fast, so your body can fast as much as you can, and have the amount of calories that you get, in a small amount of time in your day. As a matter of fact, if you can do a 2 intermittent fasting a week or 3, or maybe just one 20-hour fasting, it's just think about it. Every time you eat, your glucose raises, you have all these hormones trying to bring it down, and all the metabolic is working, right? You have to wait a little bit until everything settles, and then you eat the second time. Now, you pack all your meals in 5 to 6 hours, and then you don't eat anything after, let's say, 6 p.m. What's going to happen is that overnight, your system is going to be low inflammation. There's not going to be much metabolic situation happening at night. The glucose is not going to be, being stored or creating, lipogenic stuff. You're going to be more into the, constructing, building muscle, stuff like that.
So I have to ask you a build on this.
Yeah.
Intermittent fasting, is it the next big fad? Is it going to go away in a year? People are not going to remember it. They're like, oh, I remember that thing. Is that here to stay, or is that?
Listen, I don't know how to. I really don't know the answer, because that will be like, what do we think about the other, the paleo, the Atkins, right? When they came out, oh my God. But intermittent fasting is, you are eating a balanced diet. You're basically limiting how much you're getting or what you're getting at certain time throughout your 24 hours. So there's no more science like, cut your carbs, do a keto now, do more fat. No, you do a balanced diet. And I think that the problem is always, how to sustain that if you're not into that, right? Because some people like to snack at night. I can tell you, I do intermittent fasting intermittently. I don't.
You do intermittent fasting.
Correct. I don't do it every day. But I say, maybe if I'm going to have a big dinner on Friday, then, I'm going to try to skip dinner or eat at 5 p.m. The days, I head into that. And then that day it's going to be a late meal, etc. So you're just playing with your own physiology, and you're not doing anything wrong with it. Because that's the problem with the other diets, that you're basically the fat diet, the so-called fat diet, which are you basically subtract one of the components, which is usually the carbs, and you limit the people or the patient with that for like a month or 2 months, and it's very difficult to sustain, not to eat, carbohydrates, right? So then all of a sudden you stop, you're gonna regain, because now you're gonna start eating that stuff that is good for you, and then you go into the keto diet, which is even a little bit worse. If you think about it, the keto diet is mainly fat. And the keto diet was developed for kids with epilepsy, because of the, you wanted to nurture your brain cells with ketone bodies, which is exactly what happens when you don't eat much carbohydrates. You start your source of energy is not glucose but ketones, and the ketones are derived from the fat and the protein, takedown, basically.
So intermittent fasting, probably here to stay, but hard to know for sure.
Yeah.
You got to figure a way to fit it into your own personal habits, diet, and lifestyle.
Correct.
I'm going to ask you, first of all, you've been a great guest, but I can't let you go until I ask you this last question. When you think about, not just somebody who's a prospective patient for bariatric or for Ozempic or any other of the kind of follow-on weight loss, metabolic products out there, what advice would you give people who are struggling with weight gain or the inverse, weight loss, and they just feel like they're stuck and they're not sure what to do next? What would you advise them to do? What would be your deliberate guidance to them as an expert in this field?
Yeah, I will tell those who have recognized that they have a weight loss, a weight problem, that these people are not alone. understand that you're not alone. There's a lot of practitioners behind, the physicians, the dietitians, you know, even at your gym, you know, people that have gone through many different academic environments and, you know, and goals, and they understand this. You know, we know now that obesity is a disease. It's not a stigma. You know, it's not your fault. Okay, and we are all here to help that people. We're here to help you. You know, if it's from starting to tweak your diet a little bit to all the way to perform surgery, we're here for you. The idea is to understand that, you know, if you're feeling this, you know, and you have realized, then come out and look for help, because there's help, and we're here waiting for you.
Awesome. Omar, you are a scholar, a gentleman, and an expert too. It's been a real pleasure having you. Really enjoyed talking about this, and we'll see what happens over the coming months and years in the space of weight gain, weight loss. Look forward to talking to you about it again.